From Microbe TV, this is TWiP, This Week in Parasitism, episode 234, recorded on April 19th, 2024. Hello, everyone. I'm Daniel Griffin. Vincent is out today, so we're going to try to do this without him. Wish us luck. Joining me today from Fort Lee, New Jersey, Dixon Despommier.
Hello, Vincent, and everyone else, including Christina, of course.
You think Vincent is going to listen to us, Dixon? Is that why you're saying hello to him?
Well, we don't know. I'm sure he will. I'm looking out the window. It's kind of a gray day, but the temperature isn't so bad. It's like in the higher 50s. That's Fahrenheit. No rain today, but we had some rain. We had some really interesting rain day before yesterday and yesterday. Typical, spring weather, and thank goodness we've finally deserved the weather that we never got and are now getting.
All right. And from Glasgow, Scotland, Christina Nowla.
Hello, everybody. I've actually been to Kathmandu today briefly for a virtual tour with my husband, Richard, who was holding up his phone and he was walking me through the city and showing me sights. So Glasgow and Nepal.
Cool.
Oh, wow. Wow. Have you ever been to Kathmandu, Christina?
I have not, but having seen parts of it now, I'm really dying to go there. But yeah.
Yeah, I spent time in Kathmandu, and it was one of those people who may know about me. I was doing research. I was getting really frustrated. And what do you do when you're really frustrated? Well, I thought, just like in that famous song, I'll just take off to Kathmandu, which I did for about a month. My timing was terrible. I showed up the day of the elections, and the streets were full of red painted elephants, and that was the communists were campaigning, and the communists were campaigning on reducing the price of Coca-Cola, which was quite popular. So they did win the election, but in a democratic country like Nepal, they don't allow communists to win elections. So there was a very interesting follow-up aftermath, so to speak. But I did spend a month there working at Beer Hospital. I just loved it. Like what a just wonderful place, wonderful people.
The closest I ever got was Bhutan.
Yes.
But that's
That
not too
sounds
far
exciting
away.
too.
It's the next country over. But Christina, I can follow up on your story. My wife is currently now on a personal vacation of her own in Turkey. And so yesterday, she walked me around her apartment where she got a hotel room, I should say. And directly out the window is the blue mosque. She's about a block away from the Blue Mosque. So
wow.
She's in the epicenter. Excuse the background noise. It's not for me.
Yes. As long as you're okay, Dixon.
I'm fine. Fort Lee is on fire, but it doesn't matter. I'm okay.
It's like Monty Python. I'm not dead yet.
That's right. That's right. Exactly right. But I enjoyed, I'm going to get a blow-by-blow account of her trip, and she's coming over some Turkish delights. And who knows what else, but I'm glad she's having a good time.
It's pretty amazing that we can travel just by proxy. Yeah.
Oh, and we, if you FaceTime on your cell phone, I was told that there is no charge for that. I can't believe that. But someone did tell me that, and I don't know why there's no charge, but that's good news. At any rate, it is amazing.
All right, now, Christina, I understand we have a paper today.
Yeah, so I'm presenting a paper today, which was published in the Lancet Infectious Diseases in March this year. So in the show note, we have a link that is to the early access article. So maybe by the time you listen to this episode, it will be at an updated link, but I think you should still be able to access it as it is. I think it's free of charge, provided that you are registered with the Lancet or happy to register with your name and details. So you can actually look at that paper. So the paper is, it's got a long author list. So it's by Zinzu et al. And So I'm just going to give you the main authors and the corresponding authors, but there's quite a long list in between. So Jeannot Sinsu and David Diemert, they are joint first authors. And the two corresponding joint authors are Martin Grobusch and Ayola Adenika. So for a full list of authors, you just can click on the link in the show notes. So the researchers are from the US and from Gabon and from various places.
Quite
So,
impressive, like all the different Benin, the GW has some folks here, tropical medicine, University in Amsterdam, some
yeah,
folks from Germany. Really quite
yeah,
the author list.
yeah. It's a really quite impressive, quite an impressive list. So, the title of the paper is Safety and Immunogenicity of the Co-Administered NAAPR1 and NAGST1 hookworm vaccines in school-aged children in Gabon, a randomized, controlled, observer-blind phase 1 dose escalation trial. And as I said, it's in the Lancet Infectious Diseases. There is actually also a commentary on this article, which provides you with a little bit of an overview if you just maybe want to go back and just have a quick read. And we also have a link in our show notes. So the paper discusses a clinical trial of hookworm vaccines. And maybe I thought maybe we could just start briefly by kind of recapping hookworm infections and life cycles. So I'm going to hand over to Dixon shortly. Well, just going to start us off. So hookworm infection is actually a very common helminth infection, and we can find it worldwide, but it is mostly found in areas with warm and moist climates. And this is really conditions that make the survival of the larvae in the environment more likely. So there's two species that are relevant. The first one is Necator americanus, and the other one is Ankylostoma duodenale. These are both found in Africa, Asia, Australia, and the Americas, but there's some regional differences. So in South India, for example, we can only find Necator americanus, and this is also the predominant species in the Americas. But then if we go to the Middle East, North Africa, and Northern India, the more common species is found is Ankylostoma duodenale. So I did mention the larvae and the need for a warm and moist environment, and I think maybe at this point it would be worthwhile reminding ourselves of the life cycle. And I was wondering, maybe Dixon, if you wanted to jump in and tell us a little bit more
I
about the
would be
hookworm life
pleased,
cycle. Yeah.
absolutely honored to do so. Um, it's a life cycle that I'm familiar with, of course, for various reasons. And the main one is that when I taught at the Medical School of Columbia, that was one of the parasites that we made sure to talk about because even though hookworm has largely been eradicated, not totally, but largely eradicated from the United States, people come in with it from all over the world. And they either exhibit signs and symptoms or they are completely asymptomatic, depending on the worm burden, their own status of health, and a lot of other factors that play into whether or not you end up suffering from hookworm anemia or iron deficiency anemia, which is the main um, root cause of the pathology due to this parasite. It is a parasite that has one of its unusual characteristics, and that is you don't have to swallow it. It will swallow you. It can actually crawl through the unbroken skin. It it prefers a hair follicle rather than an area where no hair is growing. So the worm has the ability to crawl, and indeed, it's played a large role in the development of the United States Public Health Service, but I will not get involved in that later. Maybe I will discuss that some other time. But okay, we can begin with, let's start with the egg. The egg is produced by the adult female worm, which lives in the small intestine and is firmly attached to your villi by either cutting plates or cutting teeth, depending on the species. Necator americanus has cutting plates, and Ancylostoma duodenale has teeth. They're vicious-looking animals when you explode them and look at them under the scanning electron microscope. And for those of you that have our Parasitic Diseases 7th edition downloaded onto your cell phone, of course, I know you all do, you can just go to that picture and see them for yourself. And they're frightening to look at, and they should be, because the word Nicator means killer. And Americana, the American killer, that's exactly why this worm was named. The older variety, Encelestima duodenale, was first discovered in Egypt by parasitologists that came from Germany to study the diseases of the tropics, so to speak. But it was made famous by Dubini, who worked with the tunnel diggers between Switzerland and Germany, and of course,
Switzerland and Italy.
and Italy. I'm sorry, Italy.
That's
Exactly right.
okay. I've gone through the tunnel. That's the only reason why I know.
The
But you
tunnel,
are wearing shoes, I hope, right?
I was in a car, so yeah.
you know, I'll tell you, some of the tunnel workers, until they started to get more than a mile within the tunnel, these sharp rocks and everything else, cut the leather in the bottom of their shoes. And of course, being more than a mile away from the entrance of the tunnel, defecation events, which occurred on a daily basis for most people, occurred within the tunnel. And that's the reason why the tunnel workers were the focus of the study by Dubini, because before that it wasn't really certain as to whether hookworm caused a disease or not. And he was the one that established not only does it cause disease, a number of workers even died from the anemia that they were suffering from. So, okay,
Yeah.
so the worm then penetrates your hair follicle. It gets into the capillary at the base of the hair follicle. It enters the bloodstream, and it starts to circulate throughout the body, and it ends up in the lungs, goes through the alveolar space, crawls up across the epiglottis, and is swallowed. Is
Oh,
now
that always
a
gives me the GBs. The
third.
thought of it.
It is now a third stage larva. It is a first stage larva, a third stage larva when it penetrates the skin, actually, because it molts twice in the soil where the feces is deposited before the worm actually becomes infectious. So the third stage worm is seeking out a location, and the location is your small intestine. There is a symptom associated with this worm actually assuming adulthood. It comes of age by grabbing onto your villi, and there is pain associated with that initial event. And they know that because they actually gave experimental infections to people working at the National Institutes of Health in the United States to get a feeling for all of the interleukins that are generated during the life cycle. And I know one of the people that actually had that experimental infection, and they can attest to the fact that they knew exactly when this worm had hit their small intestine because of the way they felt. The worm is largely asymptomatic at that point after that initial event. The worms eat villus tissue, that's their food, and there are both males and females. And of course, mating occurs, and as a result, the females then become fertile. They begin to produce embryonated eggs. The eggs then pass out of the small intestine into the large intestine, eventually out into the environment where they hatch, and then they go on to molt several times and then become a third stage larva, which is the faleriform larva. It doesn't feed. The faleriform larva does not feed. Rather, it seeks out the highest place in its environment, and it's waiting for you. And
Oh,
when you encounter that worm, the worm then you brush up against some very small microscopic organism that you have no hint about whatsoever. The next thing you know, you've got hookworm infection and perhaps hookworm disease, which follows from a heavy infection. So that's basically the life cycle, but there are some nuance. I won't go into them, but if you have, in India, it's seasonal. It's a spring and a fall infection cycle. And during the summer months, when it's dry and when it would be unadvantageous for the worm to actually exit and try to complete the life cycles, they actually go into a dour stage. They penetrate a muscle fiber in the striated skeletal muscle tissue, and they sit there until until the environmental conditions outside change. Now, how in the world would a worm that has no access to the outside, unless they've got a radio and they're listening to the weather report, how would they actually know when the best time to exit from that muscle cell and to go on to complete the infection would be? And we have no idea of what the signals are that force the worms to hide, so to speak, and to lie dormant. But it doesn't occur in a primary infection. So it's a repeated infection. Eventually, the worms end up being sequestered in the muscle tissue until the time is right to come out. And maybe it relates to the rejection of the adults. They don't live forever. They live 2 to 5 years, and then they exit from the host. Now, if you never encountered the infection again, then you would be fine. But unfortunately, there's no lasting immunity to this parasite, hence the basis for today's paper. Is
Brilliant.
that
Thank you,
enough, or would
Dixon.
you like to hear more?
No, that was brilliant. I mean, that was way more details
Oh,
than my
good,
one
because I don't have
paragraph
any
note.
more.
So
No, I think that was
thanks. That's really
great.
good. Yeah.
Okay, good. Thank you.
Okay, so
Do I get
just
to do the clinical part, Christina?
you
You
do,
betcha.
but let me just tell you a little bit about epidemiology first, if you
She
want
hasn't
to. You
raised her
don't have to.
baton.
So I just kind of want to mention some numbers just so that we get kind of an idea of,
Oh, yeah, good idea.
if it infects only 10 people, then okay. But if it affects millions, then that's a different issue. So I think so the data that we have are not necessarily up to date. And it's also actually really quite difficult to extrapolate global prevalence from individual studies. But a number that's often kind of mentioned in the literature is around 500 million people are affected, with a range from about 400 to 700 million. But that is obviously that is a calculation or an estimation based on various different epidemiological studies. And I thought I'd just give you two examples, to give you a better idea. So I found an Iranian study that was published in 2014, and there the hookworm prevalence in school-aged children was estimated at 22%. So that I think that's really quite high. And then in another study in Ghana, which is published in 2021, so they essentially looked at the pre and post treatment prevalence in school children, and they found that the prevalence before the treatment is almost 26% in that population. So that's really a quarter of the children. So it is a really important and relevant infection. And there are variations, of course, like here in Glasgow. I don't think we have hookworm infection really, but I'm sure we used to. And in general, hookworm infections are really prevalent in poor rural communities where there is not good access to clean water and sanitation, and where maybe health education is maybe not as good as it potentially could be. So I think maybe we should also talk a bit about the clinical aspects. I think Dixon has already hinted, but maybe Daniel, you would like to tell us a little bit more about the consequences of a hookworm infection.
I'm very excited to. I realize that we must be very nerdy because I'm so anxious to talk about the clinical presentation. so, so the first is sort of what people might obviously think about from the life cycle that Dixon described is that when the hookworm penetrates, you can potentially actually get some local irritation. And it may be more so with repeated exposures because there's no protective immunity, but there might be some sensitivity that develops over time. So there can actually be a localized skin area, particularly depending on how you get exposed, right? And so we talked a little bit about that situation in the tunnel, and a situation might happen in miners. Just imagine you're a diamond miner in certain parts of Africa, and it's time for number two, time for a long call, as we call it in sub-Saharan Africa. You're probably not going to go up to the facilities. You might just take care of it there. And then later on, you might be eating your lunch and you might sit down. You might actually sit in a similar area. It's not actually the fresh feces you're worried about. You're worried about, as Dixon described, a bit of time has gone by and the hookworms are now, ready to penetrate your skin. So there might be a localized. And then the next is, yes, some people will actually develop some abdominal discomfort. We describe epigastric pain because it's a small intestinal phase that we're potentially suffering from. There's even we'll say probably less commonly known Wakana disease. And this is where, interesting enough, I don't know if this is true for the duodenale, but it's definitely true for the encyclostoma. So, am I pronouncing that correctly? Encyclostoma?
I'm not
Um,
sure. We pronounce them differently, Dixon
yeah,
and I. So
I
It's
prefer your pronunciation, Christina, by the way.
I don't know if it's
ancillosoma is the
correct.
way I learned it, but
um, but where a person might actually ingest, there actually is a way that you can get infected through oral ingestion. So think of someone who's passing the larvae in the feces, but I don't know, maybe they're preparing food, something like that. When you get a large, you can actually develop this syndrome, Wakanda disease, where you develop nausea, vomiting, dyspnea, eosinophilia. So those would be sort of the the obvious, when we think of clinical manifestations. But that's really not what gets people into trouble. What gets people into trouble is the result of this chronic intestinal infection, and particularly heavily infected individuals. The hookworm actually secretes certain moieties that lead to not only a blood loss and anemia, but you can even end up with protein loss. And so, okay, so you're a little anemic, you're losing a little protein. Well, that might not seem like such a big thing in a developed nation. But in a lot of these areas, if that's happening to a child, that can be associated with impacts on cognitive development. If you're a pregnant individual with a heavy hookworm infection, it can actually impact the developing fetus. So you can end up with, small birth weight children. You can end up with cognitive and intellectual development impacts. So when you start thinking about hundreds of millions of individuals infected, even more individuals at risk, this is a significant problem.
I must interject here and tell you that most of my information is secondhand, and it was derived from two sources. One was I was at one time a very close friend of Peter Hotez, who was one of the authors on this paper, but he's at 20 removed from the first author. And the other person that I had the extreme privilege of knowing for a short period of time, about a year to be exact, was at Rockefeller. And I was an acquaintance, and I wouldn't say a good friend, but at least an acquaintance of Norman Stoll. And Norman Stoll served on the original Rockefeller Medical Commission that uh, acted upon the findings of doctors that said that a lot of people in the South are suffering from anemia. Let's go find out what causes it. And he was one of the ones that actually found the cause of their illness. And I must say that it was the nematode was not indigenous to the United States prior to the beginning of slavery in this country.
Yeah,
So
that's what most people are thinking, that we quote unquote brought this
we
over.
did it. And
Yes.
the irony of it was that during our Civil War, most of the Southern troops, not the Northern troops, but the Southern troops, developed hookworm infection because instead of making their boots out of leather like the Northern troops had by using the hides of dairy cattle, there was no dairy farming in the South, so they shot deer and used deerskin. And
Mm,
deerskin is friable and it doesn't last very long. And so, therefore, most of the Southern Confederacy troops had leaky boots, so to speak. And the
wow.
leaky boots were primarily the difference between a Northern and a Southern soldier. One was suffering from anemia and the other one wasn't. And so
Yeah.
that's a rather ironic story and a take on hookworm that played a role in history in the United States, at least.
Yeah, I mean, the amazing thing is this is really not usually, well, it's not a clinical diagnosis.
No,
It tends to be a lab diagnosis, right? So,
that's right.
you know,
That's right.
people don't come in describing, seeing
Exactly.
worms or anything like
Exactly.
that. These really, you don't see these in the stool. They actually stay adherent. So what you
Right.
might see in the stool are the eggs, but you're looking under a microscope. So,
That's right.
so
That's right.
usually the way these diagnoses are made is with directed screening programs, but really, as we'll probably get into, is this just ongoing onslaught of mass drug administration just to targeted
Yeah.
populations. So
Yeah.
yeah, this isn't like something you'll see as like a clinical case where, Mr. Jones comes in complaining of X, Y, and Z, and don't we all recognize, maybe they have anemia, maybe they have cognitive issues, things like that. So there could be a clinical
Right.
aspect, but yeah,
Right.
usually it's this screening.
I forgot to also add the life cycle. I'm not taking up too much more time, Christina. The uh, the adult worms, when they finish chewing off a piece of villus tissue, that's their food, and we know that because once they swallow it, they move on to another set of villi, and that's too bad because the area where they vacated is now subjected to the three uh, points in coagulation that are blocked by the adult hookworm's anticoagulant that it injects as a way of keeping blood flowing. And the blood actually flows down the intestine of the hookworm and out the anus. And there's nobody that has any good idea as to why the worm needs to do that, except that maybe it's obtaining not just nutrition but also oxygen from the blood itself. And it's looked at as an open circulation for this parasite. Doesn't care. The ancylostoma causes twice as much blood loss as Necator. So there is a difference there, but unfortunately, most of the infections are primarily due to Necator, at least in our country, and perhaps also throughout certain parts of Africa as well.
Yeah, I mean, there seems like there's got to be some sort of a nutritional component here because the adult parasites are actually secreting anticoagulants, right? That are going to block host factor 10A, 7A tissue factor complex. They actually have GP2B and 3A. Let's think of your platelet inhibitors, right? That we use
Yeah,
similar things.
that's right. That's right.
And they do actually have some enzymes that help break down host hemoglobin. So,
Right.
these hemoglobin specific proteases, you got to imagine there's some sort of
You bet.
dietary component.
So, Christina, could you tell us what the, I'm not putting you on the spot, I know you know the answer, the NAAPR and the NAGST, what does that stand for?
I'll get to that. But first, I
Oh,
want to just
sorry.
tell you. No, that's okay. I did actually take note of it. I will tell you, I promise. But I just want to just kind of briefly talk about how we control hookworm infection at the moment, because I think that's relevant, because that kind of explains why we actually do need a vaccine. So at the moment, as Daniel mentioned, is drug administration. Um, Primarily in preschool and school-age children. So essentially, children are treated with albendazole or mebendazole on a regular basis. And this is cost effective and also efficient at reducing infection. But there are some issues that we could think about. So, obviously, these do not prevent reinfection. And therefore disease. And also, reinfection is really common and quick unless we also have other preventive measures in place, for example, good sanitation. And then the other issue that is potentially an issue is drug resistance that could develop. So this is not widely reported really in humans, but there is well documented emergence of drug resistant in related hookworms, for example, in the dog hookworm. And so taken together, kind of the investment into development of a hookworm vaccine, I think can be really justified. So now I think that we're all kind of up to date with our knowledge on hookworm. I think we can have a look at the paper. So there are currently no licensed vaccines to prevent hookworm infection. So two recombinant proteins are potentially uh, are the two most advanced candidate vaccine antigens, and these are the recombinant proteins used in this trial. So this is the recombinant Necator americanus, glutathione S transferase, or short NGST1, and the modified and enzymatically inactive Necator americanus aspartic protease 1, which is NAAPR1. So these are the kind of antigens that are being used. And these vaccine candidates, so these antigens or the antibodies created against them, they're thought to neutralize the enzymes targeted and potentially affect the hookworm's ability to digest blood. So these enzymes are part of two different pathways, which I think is important as it kind of provides protection from two fronts. So if these enzymes are not working properly, that impairs worm feeding, which ultimately leads to the death of the worm. So, and that has two positive consequences. So, firstly, a dead worm cannot reproduce. So, successful vaccination can reduce transmission. And then, secondly, a dead worm does also not feed on blood. And therefore, someone vaccinated would be protected against blood loss, which then would also prevent anaemia and related serious clinical consequences. And that's actually also true for an impaired worm. So an impaired worm is not able to feed efficiently, and the positive consequences for the host are really the same. But what I'd like to mention really is that these vaccine candidates, so this vaccine does not prevent infection itself, but it does provide protection from disease, and it will reduce transmission. So these two vaccine candidates, they have been trialed in adults, and they have been shown to be well tolerated and safe, both on their own and together. And when they're administered together in adults, there's no effect on the strength or the duration of the IgG antibody response. So this paper actually reports on the phase 1 clinical trial in children between the ages of 6 and 10 in Gabon, which is a country with a high burden of infection in this age group. And as far as we are aware, this is the first hookworm vaccine trial in children. So I'm going to talk you through the methods now. So I'll try to be detailed enough for anyone keen on that detail, but not too detailed to distract anyone who's just interested in the outcome. But I want to remind you that you can look at the paper. It is free to access, so you can check it out. And you can also look at the extensive supplementary materials if you like.
Could I
So
could I ask you there, and maybe this is sort of preface for what we're going to chat about. So, when I initially start, I get to this point and I say, okay, so we're going after these two enzymes, and then my thought was like, does it make sense, right? So we're going to try to somehow have a human being make antibodies that are going to target these enzymes that we think are involved in the nutrition of these hookworms. Do they
Right.
make sense as targets, right? Because we normally think like virus is sort of straightforward, like, oh, this is the protein that's going to allow it to dock with the receptor. Let's target that. Let's cover it. We're going to block the life cycle. So I was just sort of the thought experiment ahead of time. Do we expect this to work? Do we expect these antibodies to be effective? And do we expect to be able to maintain a high level, right? Because we're thinking about, I'm assuming we've got to be producing these at a mucosal site at high titer for extended periods of time. And
Right.
how many times are we going to have to be vaccinating? Is this going to then be, instead of giving somebody, pennies a pill, we're going to be having to give them a vaccine every 3 or 6 months. So just those were sort of my thought experiments before we kind of get
Yeah, no,
into like, how's this going to go?
I
I
agree.
don't know, but I can tell you it does seem to work because there was a small trial where in Washington D.C. I think on obviously people that never had been exposed to hookworm, and that was trialed, and then they were challenged with hookworm, and they seem to have been protected. But I have to admit, I did not look the paper up and read because that one that we have today is quite meaty in itself. So I thought I'd focus on that.
Right. By the way, in answer to your question, Daniel, they've tried multiple antigens prior to this one. And the first ones they thought about were the ones involved in coagulation.
Mm-hmm.
And so they
Hmm.
had isolated the proteins and the genes and made, recombinant proteins. And the antigens were tried. They didn't work out too well. And Peter Hotez, had identified an enzyme that the worm uses to penetrate the unbroken skin with. It's a
Yeah.
digestive enzyme. And he sort of hooked his wagon to that one for a long time. And he actually did some clinical trials in China. And they didn't pan out because those worms are hard to stop. And
Mm,
even if you had 20% or 30% of success, that's still enough to cause clinical disease when you're heavily infected. So I think
yeah.
that's why they moved to these. And I was surprised, as you were, to see the glutathione transferase. That's pretty exotic, but very interesting protein, which schistosomes also share.
Yeah.
Not exactly the same protein, but it's an antigen also
Mhm.
that Schistosoma mekongi has been, well, they treated the water buffalo with the protein and then prevented Schistosoma mekongi from infecting the cattle. But this one is in, I don't know what role it plays in digestion. I have no idea. Uh,
Yeah.
it's a transferase, so maybe we have to
Yeah.
get Peter on the show to find out.
Yeah, I mean, well, the other interesting thing, right, and just sort of, and we're going to go through this, so maybe I'm trying to create a context. So I said, okay, so interesting enough, we're going to target these. Okay, I'm not sure I would have picked these, but maybe we're running out of options. Maybe so many failures. We're going down this road, and
Mm,
we'll see.
could be.
And then the other, what would I have wanted to measure? Am I going to want to measure serum IgG, or am I going to want to measure some sort of mucosal immunoglobulin? So we'll sort of see where all this goes. I have read the paper, so I know where it goes. But I just want to sort of set the thinking. Like, how are we
Yeah,
thinking about it? Because at the end of the day, the question will be, does this work?
yeah,
But yeah, so all right,
yeah. And we won't give you the answer to that in this paper, but we'll get somewhere.
Indeed.
Somewhere, yeah. Okay, so just want to clarify. So this study was approved by the National Ethics Committee of Gabon, and it was conducted under an investigational new drug application to the US Food and Drug Administration. I mention that because I think it's really important that we undertake research, clinical trials in an ethical manner. So parents, so I did mention that this is a clinical trial on young children. So in the first instance, you would be approaching parents. So the parents or the legal guardians of potential participants were recruited and explained how the study was going to work, and they provided written informed consent. And then the children whose parents or guardians had consented, they did also consent after receiving an age-appropriate information. And I think that's also important because, you know, I mean, having brought up 4 children, I know even at the age of 6, actually, they have opinions and thoughts, and they know what they want and don't want. So I think that's important to mention. So the study was conducted in Gabon in the Lambéren region, and this is a region where we have Necator americanus in children. It's very common, and so the average age was about 7.5 years. So children between the ages of 6 and 10. And before the start of the trial, all the children, they were screened for ovan parasites, and they were treated if they were infected with any intestinal helminth, but also if they had a schistosoma hematobium infection. So the children were then enrolled into 3 cohorts, and this was done in an open sequential method, which means they were not masked at this stage. But for the actual clinical trial, they were masked. So the vaccine allocation was then done in a randomized observer masked way. So I'll try and summarize these 3 cohorts as succinctly as I can. You may have to stop and rewind and go back because there's quite a lot of information there. So each of the 3 cohorts, there were 20 children, and each of the cohort was divided into 4 groups. So 2 groups of 8, they received 3 doses of the vaccine, and there were 2 vaccine schedules with vaccinations at either 0, 2, and 4 months, and and or at 0, 2, and 6 months, so slightly longer. And 2 groups of 2 children, they received a control vaccine, which was the hepatitis B vaccine and saline. And the 3 cohorts were identical, except of the dose of the hookworm antigen that was given in the vaccine. So cohort 1 received 10 micrograms, cohort 2 30, and the final cohort 100 micrograms. And what's important to notice here, so we have 2 antigens, and actually these antigens were administered separately, one into each arm. And for the control vaccine, one arm received hepatitis B vaccine and the other a saline injection, really just to make sure that nobody knew that they were getting the control. And actually, there's a diagram in the paper that's figure 1. And in this table, you can also see how many children did not complete the trial. And actually, I think the completion rate was really good. Only 3 children did not complete, 1 because the parents had withdrawn consent, and 2 because they had moved away. So obviously, the researchers wanted to make sure that it's a safe trial. So the cohorts were not all vaccinated at the same time. So the first cohort received their vaccine and they were monitored for 2 weeks following the first vaccination before they then started with the second cohort. And then again, the second cohort was monitored for 2 weeks after the first vaccination before the third cohort was initiated. And that makes sense because there were increasing amounts of antigen administered in these 3 cohorts. And then there was a lot of data collection and sampling and data analysis. So I will not talk about the statistical analysis because statistics is one of my weak points, but I'm mentioning it because it is really important because that gives strength to the results that we'll have. So now I can tell you about the outcomes and the results. And I'm kind of mix that together a little bit. So the primary outcomes for this study were safety and reactogenicity. So this study was not meant to look whether the vaccine was efficacious, just to make sure it was safe and that an immune response could be observed. So let's look at the safety first. So for that, adverse events were recorded, and this was really very detailed. They were recorded throughout the trial and up to 9 months after the final vaccination. And they recorded 3 types of events, and each of these 3 were grouped into mild, moderate, and severe. So the first group of events were injection site events, for example, pain and tenderness and maybe swelling. And then the second type of events were systemic events like fever and headaches and muscle and joint pains, maybe vomiting, nausea. And then the third type of adverse event they were looking for were clinical laboratory events. So these children had blood tests done, for example. So they were looking whether they had reduced hemoglobin or reduced platelets or generally changes in their blood counts. So are the vaccines safe to use? And your short answer is yes, but I'll just give you a few more details about that. And I think this is quite interesting. There were no withdrawals from the study due to adverse events, and there were no severe adverse events relating to the vaccination. There was only 1 adverse event recorded, but that was a strangulated inguinal hernia, so very unlikely to be related to the vaccine. So injection site events, so these were mostly quite mild, and they were tenderness and pain, and they were more common in the hookworm vaccination compared to the control group. And there was no significant difference between the dosage groups. But between the 2 vaccines, so between the 2 antigens, there were slight differences. So the NA-APR, so which is can't remember now, what was it again? A transferase vaccine. So they were slightly more common than with the GST vaccine, and that was statistically significant. With regards to systemic events, the most reported ones were headache and fever in 25 and 20% of the children respectively. And all but 3 of these were mild. And the 3 that were not mild, they were probably unrelated to the vaccination because these children had malaria. Again, there was no difference between the dosages, and again, the events were more common in the hookworm vaccination group compared to the control groups. Then with respect to kind of lab results, so most common were slight decreases in hemoglobin, and none of these were considered severe, and none of these could be definitely or probably related to vaccination, and they all resolved spontaneously. And in the second clinical event that they noted was thrombocytopenia, so low platelets, and that was reported in 5 children. 3 of these were reported as severe, but not considered or were considered unrelated to the vaccine, and 4 resolved spontaneously, and a 5th one had not resolved at the end of the study but was not followed up. So I think in summary, we can probably say that co-administration of these 2 vaccines in children of this age group is safe and well tolerated. And there's no significant difference between the dosages, and there were really no serious adverse events that could be attributed to the vaccine. And the events were mostly mild and short-lived. So I think, from a safety perspective, I think that is acceptable and actually comparable to what was found in the adult trial. So I suppose now that we know the vaccine is safe, I'm sure you're dying to find out if it's actually eliciting an immune response. And the short answer is yes, but I'll give you a little bit more detail because I know you like detail. So Daniel alluded to what they were actually looking for earlier. So here in this paper or in this trial, the reactogenicity was determined by measuring IgG levels in the serum against the 2 antigens, NAAPR and NAGST1, at several points during the study. So they were measuring serum levels of antigen-specific IgG antibodies by ELISA. And I suppose I could put a little diagram of an ELISA in the show notes. I don't know, do I need to go into any details?
I don't think so. I think,
No.
just
Okay,
think of it as
right.
we're using a certain
Yeah.
technology to
Yeah.
get quantitative IgG levels.
Okay, good. I did have a diagram in my notes just in case.
I remember doing handmade ELISAs in the lab many years late at nights.
Yeah, we still do ELISAs with our DTMH students. So yeah, it's quite fun. So important to mention is that a baseline was established before the first vaccination. And then we just have an enormously large set of 2 tables that summarizes all the results. And that's table 3 and 4. And they go over several patients, but I'll summarize it. I think a bit more. Yeah, I think they're quite difficult to actually see. The data don't jump out at you, so I think I'll try and summarize it. So for both of the antigens, the peak IgG levels were observed 2 weeks after the 3rd injection, and that was regardless of the vaccination schedule they had. And the smallest dose, the 10 micrograms, they did only elicit a really minimal response. So for one of the vaccines, the NAAPR, the peak response was seen in children with 100 micrograms dosage, and for the schedule of 0, 2, and 6 months. The response was lower in the shorter schedule, 0, 2, and 4 months. And the control vaccination IgG levels, which is important, they remained at the baseline. For the middle dose, the 30 microgram dose, the pattern is similar, but the response was significantly lower than for the 100 micrograms. And then if we look at the other antigen, the NAGST1, the patterns of response observed were similar, but on the whole a little bit lower than those of the other antigen. So this is where statistical analysis really becomes important. And I'll just tell you the method that was used. That was a linear mixed effect model fitted with log transformed IgG responses. Now, I have no idea. I couldn't do it without opening a statistics book for dummies. But anyway, that identified that statistically significant antigen dose response effect for both vaccines. And the p-values are 0.0001 for both, or less than 0.0001. So I think that's statistically quite significant. And then the statistical analysis also identified a significant vaccination schedule effect for both vaccines, slightly higher p-values at 0.01 and 0.04. The response was generally higher in the more extended schedule, so 0, 2, and 6 months, as opposed to 0, 2, and 4 months. So I think in summary, antigen-specific IgG responses to both vaccines were induced in a dose-dependent manner, with peak levels observed 2 weeks following the final vaccination, and regardless of the vaccination schedule. But actually, the schedule effect that I mentioned earlier, so the higher response, is not surprising. We've seen for other types of vaccine that there is an improved immune response when the interval between vaccinations is slightly extended. And I remember there were lots of discussions about vaccine schedules. When we first had the COVID-19 vaccine, I think there were quite differing approaches used, for example, in the US and the UK. But it has been shown for many different vaccines that the immune response is improved. And that's probably because there's just more time for the immune response to maturate. And then, so kind of, when we now look at the IgG responses in children and we compare that with the previous study in adults, where the same schedule and dosages was used, the pattern were actually quite similar. So in a way, that's a replication, I would say, although we had a different patient group. And then the other thing maybe that's come out is actually that the children and the adults in both the studies, that they did actually have a low baseline IgG response to the vaccine that was higher than that of adults that were participating in a different trial in a non-endemic area. So that means that the baseline IgG response is probably due to prior infection and not cross-reaction with similar proteins. So I think that's that's another kind of nice control that is discussed here. And then the other things when we compare children and adults, so the adults is a different paper. We could maybe provide a link for that as well. So it appears that in children, the response is generally higher, which I don't think is unexpected because children often have a more active immune response, and that's also been seen for other vaccines as well. So I suppose we can maybe just now open the discussions. I kind of think, well, what do we need to do next? Obviously, we need to now find out whether that immune response is actually protective, not from infection, but from anemia, and maybe also reducing transmission. So, and maybe the trials could look at the primary endpoints could be, I suppose, egg load. We could assess the burden of infection and also anemia. I think that would be a good endpoint. So yeah, let's bring you all in again because I need
Dick
a
said you first.
drink of water. I need a drink of water.
Well, I have two burning questions in my mind. The first one you addressed by not knowing whether 100 micrograms, which gave the highest response for IgG of the three, is enough to actually have a clinical effect on the outcome of the infection, number one. Number two, prior to that, though, there's a control group, there's another group missing in their clinical trial that they're going to have to run before they start this vaccination program. And that is that they have to combine the two vaccines together into a single injection. If you don't do that, then this is going to become a very clumsy public health procedure to get the kids all lined up, to have two people, one on either side, to make sure that it's just it's unheard of. And so
Yeah,
I don't know why they didn't throw a third group in there, probably because they couldn't find enough kids,
maybe,
um,
yeah.
to participate in that combined vaccine, because a lot of vaccines contain, up to 9 different proteins, and they're still effective, like the PVV, yeah, human papillomavirus, I believe, has 9 different constructs as part of its vaccine.
Yeah,
By the way, were all these recombinant proteins, or were these isolated from the parasite?
they were recombinant.
All of them were.
Actually, I think the answer to why they were not mixed is because I think they were in different, I
Yeah,
don't remember the exact details, but I think they were in different adjuvants. So there's definitely some work needed on that because, yeah, nobody wants, I mean, we already have so many vaccines.
it's enough already.
Could
I
I,
don't
yeah, could
want
I
more than
ask
one
about
needle.
that? I was sort of confused by that because they, in their procedures, they say injections were administered intramuscularly in the deltoid of each arm. So are they putting one in the right deltoid, one in the left deltoid, or just trying to figure out
Yes,
how they.
I think that's what they did. Yeah, one in the left and one in the right, and that's why they had to have a saline and a hepatitis B control, so that the controls would also receive two vaccines. Um,
Is that an
yes,
unusual muscle to use?
I don't know. I don't actually even know what the deltoid is. I just
It's like
assumed
your
it was
Deltoid's
the
back.
up
upper
here, what
arm.
you're,
Yeah,
yeah,
It's
it's
yeah,
what you're,
like the
the
it's
upper
what
arm.
you're used to. But
yeah,
yeah, it
yeah.
is. That is definitely an issue because I think there is adult data that you could just give both of these and get good so yeah, I don't know. I almost wonder if it couldn't be two needles very close to each
Yeah, I
other
was
with
thinking
a
about that
common
too. Yeah,
plunger. Just can they be? Because I
yeah,
had
right.
well, I'll let you because I have a few comments too. But Dixon, you go on because that was an
No,
excellent first
that's
comment.
basically it. Because I think that every clinical trial has some drawbacks and some disadvantages and advantages. And this, it's obvious that there's no problem in finding children in an endemic area to test out this vaccine. All they have to do is just turn them loose and let them acquire hookworm and see what the rate is among those that got the placebo versus the vaccine. Um, they're going to have a difficult time sorting out the 10, 30, and 100 microgram groups when they look for the numbers of parasites and the clinical effects. And it's a complicated study when you go beyond the vaccine safety
Mm.
issue.
I
Because,
think though they wouldn't go for that lower doses because like the 10 micrograms didn't really elicit much of an immune response and the 30 also much less. So they probably would, I would assume they would go forward with the highest
well, what about
possible.
200 or 300 or
I don't know, I
500?
suppose, yeah.
What effect? It depends on the outcome of their clinical
Yeah.
trials for whether it protects or not.
I guess you just have to consider how much protein you can load into a single injection. I don't know, whether these, I suppose having worked with proteins in the lab a long time ago, sometimes they're more soluble than other times. So
Yeah,
that may
that's
be an
true.
issue. Yeah,
Well, being insoluble might be an advantage.
yeah,
It might act like a
maybe.
depot,
Yeah.
and allow the slow release of the antigen from an injection site. That I don't see that as a major problem, but I think the biggest problem will be to work out a single injection for both antigens. I think that's going to be you can't use this data for that.
Yeah, I'm looking at the adult study, right? The one that you mentioned
Mm,
in Washington, and really, they're also described as co-administered instead of just somehow, giving you one shot and getting both, which, yeah, logistically is an issue.
mm.
But I think it
It did.
does get it
It
a
didn't
couple.
explain
Yeah.
why, did they? Because I don't remember reading
Yeah,
why.
that seems like it would be nice, and of course, they're just, the comment is just, lauding them and not sort of the level of, I guess, scientific rigor and criticism I would like to see. But anyway, that being aside, they bring up a couple important things. One is we don't know what level of serum IgG is sufficient to protect against anything,
Mm,
infection,
Right.
disease. I think disease is really what we're looking here because they say in their comments, say sufficient to protect against infection, but we're not looking at protection against infection. We're looking
no,
at
that's
protection
true.
against disease. And we do have, sort of, crazy to me that this might actually be working. But I left a link in our show notes to the canine, which is an efficacy study. So in canines, if you actually give this to canines, you actually see some benefit. You actually see a reduction in weight loss. You see a reduction in parasitic, egg
Worm burden or
when
egg output?
analyzing,
Yes.
yeah, egg output. So you are actually, so we do have the canine efficacy data, and now we're going to try to figure out, does this work? And who do you really want to know? Does it work? It is really going to be children. So, I think
Right.
what we can take away from this is that it's safe. You can go all the way up to the 100
Mhm.
micrograms. It's just as safe as any other dose. So why not go with that? And then maybe the next step is now that we see this is safe, is to actually do an efficacy trial.
Mm.
So,
Yeah.
okay,
Yeah.
go ahead. Maybe we're going to figure out some way to get the syringes, somehow, with a single plunger, so we don't have like one person on either side, which is not the end of the world, in all honesty, if this actually works. But yeah, maybe we're ready for some small pilot efficacy trial at this point.
The other
Maybe, yeah.
question I had, of course, is just arose as I thought about this. Is it possible that one of those antigens will have a more protective effect than the other? And so, would you have to actually immunize separately with each antigen and test their clinical efficacies against disease rather than giving them both together? Because you'll never know if you gave them both together which one had the most effect in reducing disease.
Well, they did measure the antigen the antibody response for the separate ones, and I think the NAGST one I think elicited a lower response. So maybe I don't know. I mean, a low response doesn't necessarily mean less protection. Um, I suppose we just have to go in and try.
Hmm. Sounds like a fishing expedition.
Well, I guess that's the interesting issue that we got to this point, right, where we have animal models showing that if you go ahead with this approach, you actually can get protection.
Mm,
And it's just sort of this, and now we're seeing you can give both and it's fine. They don't interfere. So you can get
yeah.
antibodies against both of these targets. Everything else has failed to date. Is it worth seeing if there's efficacy to this approach? Because there doesn't seem to be a downside to giving both antigens other than whatever logistics getting those two shots in there.
Mm,
Safety's fine, tolerated is fine. Because you're not going to be able to keep throwing darts at the board and missing, right? So at some point, we've got to get something that can show some efficacy. But then
yeah.
the other, and this is always the challenge, right? We always talk about vaccines as the holy grail, but we don't have hookworm vaccines here in the US. We have sanitation. We
Right.
have people actually, not being exposed to human feces that's, sat in the soil. We bury people 6 foot down. We dig our latrines, if that's even what we're going to use, so that it's 6 feet down, so that we don't
Mm,
keep exposing. We distribute shoes, which was actually part of what happened in the South, right? Because we didn't get rid of hookworm in the South with a vaccine. We got
no, we
rid
did
of
not.
hookworm in the South by addressing poverty and shoes and toilets and
And a
things like that.
behavior change. That's right.
Yeah.
Yeah. And
Right.
behavior in a
Yeah.
good way. Like people would rather like have access to a proper place for their feces to go rather than just sort of walking around and stepping in it, right? I mean,
Understood.
Oh,
But,
absolutely.
but,
Yeah.
but, but, human feces is the basis for most fertilizers in less developed countries. And you're destroying a product that could be used to raise food. And that's the problem that the China Medical Board ran into when
yeah,
they tried to take the U.S. model of digging a latrine and getting rid of feces
yeah,
to China. China says you can't do that because we use the feces as fertilizer. So now you have to figure out something else. What
yeah,
they did was they set up these big bowls,
yeah.
which were called kongs,
Hmm.
and they allowed them to fill up. And when the sixth one was filled, which should take about 2 months to fill up, the first Kong could then be used to fertilize the soil without transmitting hookworm because the larvae were dead. But there were lots of other things that weren't dead, like
I was going to say there's
poliovirus
other
and
stuff that's going to
giardiasis
be
and
in there.
histolytica, and you can name all the other parasites
Yep.
except maybe strongyloides that would have survived all of that, and their public health programs were limited to just the hookworm, whereas the
Yeah.
U.S. program conquered all the diseases that were related to fecal transmission, and that's a big difference.
Yeah. How do we keep people from using night soil here in the U.S., Dixon?
Just ask the U.S. fertilizer corporations, and they'll tell you. I mean,
Yeah.
the fertilizer business is huge.
Yeah.
Once they learn how to make it from nitrogen
I'm
from
still
the
reading
air,
Silent Spring, so maybe there should be a whole section on the
you
we may have killed all our birds and poisoned a lot of people, but we got rid of
We have no
hookworm.
that's right,
hookworms.
exactly. Well, that's what they
Yeah.
said in China. That's
Yeah.
exactly what they said. Although
Uh,
they looked at that as a major accomplishment, it was not enough.
yeah. So no, maybe if night soil continues to be used, human feces continues to be an important part of agriculture, then maybe we're going to need a vaccine.
That's right. Well, the good news is that Dubai just got inundated with a flood that they've never had before. And the people who suffered most, in addition to the citizens of Dubai, of course, were the owners of greenhouses, which flooded out and
Hmm.
destroyed all the crops. There were a number of vertical farms also in Dubai, and none of them suffered,
Mm.
not one.
Interesting.
And
So
I just
yeah,
read an
so
article on that today.
vertical farms as a
Is that
hedge against climate change.
you got it?
And you wouldn't be
That's
using
exactly.
night soil on those either.
And Christina, you are right on the money. You're right on the money, and that is the solution to soil transmitted parasitic and diseases in general. As long as you don't have to use soil to grow your crops with, you're in good shape.
All
I
right. Are
suppose
you going to
we're a
paste in
long
a
way
link?
from
Are you
that.
going to paste in a link to the new city in our show notes, Dixon? So
We should,
I,
yeah.
I did finally read that book,
Did
and
you now?
I'm always a little cynical. I spent too much time around you, Dixon, but it's worth a read. There's a lot of really great
It's
ideas in there.
worth a
So.
read, he said, especially when the book was free.
No. Remember, I went and I bought one so that I could, at some point, when I get around to it, go on Amazon and leave
A
a
review.
critique as a
Oh boy, I can
verified
hardly wait.
purchaser.
I'll read it when it's available as an audio version
No,
because I find.
there is.
Oh, there
That's
is. Okay,
yeah.
brilliant. I'll download
But
it
you
and
want both, Christina. You want the
okay,
audio version
because
because
it's got images and stuff in it.
yeah,
Yeah,
you
And
also
yeah,
want your
yeah.
listen, if I make it to New Orleans and you're going to make it to New Orleans, I'll bring you a copy.
I'm not gonna come. I don't think.
Oh, you don't. You're going to miss
I
out on
don't
the best
think
meeting.
so.
Oh,
Yeah.
the food.
I'll think about it.
I
Anyway,
swear.
I
Yeah, go
suppose,
ahead. I'm sorry, we're drifting off the topic, but
yeah, well, just to bring us briefly back, I just kind of thought
yeah,
I chose the paper because, we don't actually have many anti-parasitic vaccines. And I
you're
just
right.
think,
No, you're absolutely
every
right.
time I see, we did discuss one, what was that animal worm called with a complicated name not a long time ago, Ostertagi.
Yeah,
Yeah. And I just thought, oh, yeah, this is amazing because, there's just not enough anti-parasitic vaccines out there. So,
oh,
and
you're right.
that's how it caught my attention, really.
Thank goodness for ivermectin.
yeah. Well,
Good.
that was fantastic. So
Excellent.
I know we're
No,
making you speak and speak, but I think Christina, you also have our
I have
hero
a
this
hero,
week.
yes.
You're like taking the whole show. This is good
I
stuff.
know, I know. I'm gonna be, I don't know, I'm gonna need some lozenges after.
We'll
Yeah,
give
I
you
do have a
we'll give you 2 weeks off, Christina. How about that?
that's
thank
right.
you.
That's very funny. Very funny.
Yeah, I do have a hero, and I'm actually kind of
Excellent.
stay with the Scottish trypanosome themes. So today I want to talk about Muriel Robertson, who was a Scottish scientist who lived from 1883 to 1973. So she died shortly after I was born. So mild overlap, but obviously no encounters. So the information I'm presenting today is from a special issue in the journal Parasitology, which is published in 2017. And the special issue is actually called Glasgow Encounters with Tropical Disease. And the article, so it's a really quite very detailed biography of Muriel Robertson was written by my former lab mate, Dr. Tansy Hammerton. And I put a link in there. I mean, it's really interesting. I'm just going to, it'll probably feel quite long, but I have only really picked, you know, what do you call it? The nicest bits are kind of I don't know, just some really fascinating myths about Muriel Robertson. So, and actually, I was thinking as I was writing that up, I thought, oh, I should have produced her before Keith Wickerman, because a lot of the work, some of the work that Keith Wickerman was actually continuing on from Muriel Robertson. But there we go, hindsight and all. So Muriel Robertson, she was born in Glasgow in 1883, and she was the seventh of 12 children and in a comfortably wealthy family. She was home educated, which I think was normal for women at the time. And she was really good at picking up languages. So actually, that came in very handy throughout her career because she picked up the languages of where she worked. She wasn't formally taught scientific subjects because that was just not done for girls at the time, but she was exposed to science through family connections and friends. And from what I read, she was an adventurous girl, and she was also given quite a lot of freedom, for example, to explore the Scottish Highlands on horseback during family holidays. So probably quite an unusual childhood for a girl of that time. So Muriel, she went on to study for an arts degree at the University of Glasgow in 1901. And so an arts degree at Glasgow then looks quite different from what I imagine an arts degree is now. So Muriel, she studied a broad variety of subjects really for that degree, and that included languages and math and logic and botany and zoology. And so zoology and botany, she studied under Graham Kerr, who was quite a progressive scientist who believed that women should be educated alongside men. And again, that was quite unusual. And actually, Graham Kerr, within our university on campus, we have one building that is named after Graham Kerr, and it houses a lot of research and lecture theatres, but also the Zoology Museum. So if you pop into Glasgow and you have 10 minutes of spare time, you should pop in there and go and have a look. Anyway, so she was given a space in the lab. She undertook studies into protozoan organisms, and her first publication was on a protozoan parasite of green algae, which was published in the same year as she graduated with her master's, with her MA. After her graduation, she spent some time researching the life cycle of skate trypanosomes. I find that quite astonishing. I mean, who would have thought skate have trypanosomes? But there we are. And she actually demonstrated that these were transmitted by leeches. And she did study the life cycles of many, many types of trypanosomes. For example, trypanosomes that infected tortoise and rat and fowl. I find it really remarkable that trypanosomes infect so many different species, from fish to reptiles to birds and mammals, and also that there are so many different intermediate hosts. So we have the tsetse fly for human African trypanosome. We have leeches for that skate trypanosome. So yeah, that's really quite interesting, and leeches are probably the only organisms that really give me the heebie-jeebies, or could possibly make me screech hysterically if I were to find one attached to my leg. So yeah, I don't like leeches. I guess that's not relevant. But what she did, so that research on those trypanosomes, that prepared her really well for where she was going to go and where she was going to do next, or what she was going to do next. So between 1900 and 1920, there was an extensive sleeping sickness epidemic in Uganda, and that resulted in probably about 250,000 of deaths, and there was also a huge population displacement. So in 1911, Muriel was offered a temporary appointment as protozoologist to the Protectorate of Uganda. And, considering that at the time not many women were prominent scientists, I think that was a really remarkable achievement. So from this time, she published 5 key papers on various aspects of Trypanosoma brucei gambiense life cycle, and she earned a doctorate of science, again from the University of Glasgow in 1923. And actually, these studies were instrumental for the work of our last hero, Keith Wickerman. So maybe the order was not very well chosen. So one of Muriel's hypotheses was that the life cycle stage in the salivary glands of tsetse flies was crucial to the progression of the life cycle, which was contrary to common assumptions at the time. And another important contribution was that she demonstrated the importance of the game reservoir for the maintenance of spread of trypanosomiasis. So during the First World War, Muriel was unable to work on trypanosomes, and she shifted her work or interest to anaerobic bacteria. And her work on Clostridia during the First and Second World Wars really made significant contributions to the understanding of anaerobic bacteria and to the development of antitoxoid vaccines. I guess that would be a story for another podcast, maybe TWiP. So moving forward in time, Muriel made also significant contributions to our understanding of a very different parasite, Trichomonas foetus infection in cattle. And this really triggered a change in farming practice and quickly reduced the prevalence of this quite significant infection. And then in 1947, she became a fellow of the Royal Society, and she was only the 8th woman to be elected into this society. She was also a fellow of the Royal Society of Tropical Medicine and the Institute of Biology and other societies, including as a founding member of the Society for General Microbiology. And she was an honorary member of the British Society for Parasitology. And posthumously, she was a nominee for the Saltire Society Scotland Outstanding Women of Scotland Award in 2014. So quite a remarkable woman. She retired in 1961 and enjoyed many years of retirement until her death in 1973 when she was 90. So I chose her because, I don't know, women scientists in that area are not that common. And I admire her for achievements and the work that she did. And I just can't really have been easy as a woman to be a scientist and such a successful scientist during that time. I mean, it's still challenging for women now, although nothing compared to Muriel's difficulties that she must have encountered. But I really admire her for having such an amazing career. There were also 2 world wars in that time as well. So I think she did amazing. So, and that's why she's my hero.
Tremendous. Yeah, so I know that you don't like leeches, so that maybe I would see if I could magnify your horror relative to leeches. Recently, there was a case that if you listen to Puscast, when I record it next week, there was a 2-year-old child that ends up coming into a mission hospital in Kenya, with anemia, very weak, and actually is vomiting up some blood. And, the physician on call admits him, like, I don't really know where the blood's coming from. But then, you ready for this? Later that day, after a local physician noted that the presentation could be due to an unrecognized leech infestation,
Really?
he looks in and he visualizes with a laryngoscope a leech attached deep in the oropharynx, grabs it with forceps and pulls it out.
Oh, that's horrendous.
That's why I've always been against baptism.
Oh, that's disgusting.
Yeah.
Oh,
So if you didn't like leeches going into this, then just watch the African Queen and one more time and
there's
think
a
of
good
this
follow-up here
story.
too, Daniel, because it's called the medical leech.
Well, we still do
use leeches,
use them, yeah. And
Virulo medicinalis, but it's not as good as coagulating blood as hookworm.
Yeah, so we should somehow get
works
hookworm.
in one place.
Yeah, no,
I suppose hookworms, they live outside, whereas hookworms generally live on the inside, so maybe a bit more difficult to prepare.
Yeah, I remember a little boy with he had his finger severed, and then it was sewn back on with microsurgery.
Mm.
And so he's got the finger sort of held up in one of these things and a little leech on the end. And the leech,
Oh,
you get
yes.
special ones because they can have Aeromonas. So you got a special Aeromonas-free medical leeches. And
Wow.
so the leech is basically maintaining blood supply while the finger
Mm.
healed and
Wow.
reattached. And
Yes, amazing. Yeah.
I was going to
yeah.
also add that Muriel Robertson's switch from anaerobic bacteria did not stop because Trichomonas fetus is an anaerobe.
Yes, that's right. Yeah, yeah,
So she
yeah.
stayed
Yeah.
well attached to her.
Yeah, I kind of remember a leech story. Well, I didn't actually have a leech then, but I did have a biology teacher who said, "Oh, we were talking about coagulation and blood clotting and stuff." He said, "Oh, I always used to have a few leeches, and I used to put them on the girls, and they were screeching far better than the boys." But then he kind of complained, "Oh, but we're no longer allowed to use that because that's not safe from an infection point of view." If we then move them around, I was thinking, oh God, so
Yeah.
maybe my aversion
It
comes
was
from that
never safe
time.
from an infection point of view,
It's true.
sir.
As I
No,
recall,
I guess not.
there's a disease in, I believe, reptiles, which is transmitted. It's a trypanosome, which is transmitted by leech.
Well,
Wow.
the skate one as well. Ew,
Yeah.
ew.
Yeah,
Yeah,
Amazing.
not going
yeah,
anywhere
yeah.
leeches.
All
That's
right. So
Anyway,
that's TWiP 234. You can find the show notes at microbe.tv/TWiP. Send your questions and comments to twip@microbe.tv. If you like our work or you just want us to keep doing it, consider supporting us. Go to microbe.tv /contribute. There's a big contribute button on the main screen now.
Yeah.
And Dixon Des Pommiers, you can find him at trichinella.org, thelivingliver.org. Thank you, Dixon.
You're welcome. Christina, I want you to do the shows from now on. This was wonderful.
oh, thank you.
No, really,
Thank you.
it was
It's
very
taken me
thorough.
2 days, but
No, it was right on
I did
point.
really
Right
enjoy
on
it.
point.
All
Thank
right.
you.
And Christine Nalla, you can find her at the University of Glasgow. It's worth the trip. Thank
It
you, Christina.
absolutely is. Thank you. It was really really enjoyable tonight. I really enjoyed myself.
Good
All
stuff.
right. I'm Daniel Griffin from Columbia University Irving Medical Center. You can also find us all at microbe.tv. I'd like to thank the American Society for Microbiology for their support of TWiP and Ronald Jenkins for the music. You've been listening to This Week in Parasitism. Thanks for joining us. We'll be back in 2 weeks.
Another TWiP?
TWiP is parasitic.
I thought I was going to do it, but that's okay.
No, do it. Do it.
No, you did it absolutely fine.